have the next speaker, Dr. Rohit Saxena, who will take over on the very important topic of surgical skills and enhancement schedule. Rohit is a professor of ophthalmology and heads the department of pediatric endophthalmology at RP Center, and has been a great friend and support as a member ARC North, and I truly miss him. That is if I continue. So
thank you, Chitra. That's been some wonderful years here at ARC, and of course we've been past so many years trying to see how we can get each and every subspecialty to enhance its level of training of the fellowship, so that overall we see a far better set of fellows, senior residents in our case, who go out and are able to kind of push our specialty beyond the boundaries that we've seen it limited to at the moment. So I'll be talking about skill set enhancement, and some of it was discussed in the questions that we had. So more of a run through so that we get some diverse ideas from various institutions, and we can collate these ideas together to try and have these institutions get information from other places and get better. So essentially, advances in surgical skill training would be helping in transfer of these skills from one generation of the surgeons to the next. Particularly important in strabismology, where I would say, fortunately or otherwise, we do not have so much access to topographers and laser machines that do a lot of work for us. So we still are down to doing all these things with our own pair of hands, and therefore to actually magnify the impact of what we are doing and all the training that we have, we need to transfer these skills on to the next generation, so that the good work that we have achieved goes on forwards and becomes even more. So the basic challenge again becomes, because we don't have too many tools to transfer or train them on, and they are again more white matter work. So the more that they have get to do, the better they'll be, and the risk is that the more they do, the more complications we have to manage. So this is that double-edged sword we have to work and try to establish a surgical curriculum that balances these two and standardize the acquisition and the evaluation of the surgical skills. So just as a start, for any surgeon, you need to be very important about basic life support and CPR. Strabismology, because we do use a lot of blocks as compared to cataract, which has actually moved a lot, adult cataract, which has actually moved a lot to topical, and of course pediatric cataract, where we have the support of the anesthetist. So when we are operating under block, we know that the risk, in fact I feel for cataract surgery, the riskiest part of the patient is the time when we are giving the block. I think the maximum complications now are probably in the block time. So same for strabismus. It's very important that our residents should be trained not only in giving the block appropriately. Sometimes we can get good akinesia, but we do not get good anesthesia, and the patient is jumping and crying all throughout while you're just keeping on infiltrating anesthesia again and again and again. And those are times when we are struggling. So it's very important for them to be able to understand how to manage these situations, and of course maintenance of the sterility inside the operating room and all the techniques that all residents and everybody who is in the OR should know about. From ophthalmology and strabismology, it's important to know about the relevant anatomy, to be able to understand the various principles of the surgical procedure, the tissue handling that we're doing. So residents, especially residents who rotate to us from the retina side, who have good experience of assisting buckling, are kind of uncomfortable with our gentle handling of our tissue. And of course, nothing against fellow retina surgeons, some who may be sitting here. But I'm just saying that obviously their purpose is different and our purpose and approach is different. So it's important for them to get oriented with the way we find tissue handling to be there. And again, like I said, management of ocular emergencies that can come up. So these are very, very important things of skilling of the resident and the fellow that are essential before we start them. So before the operating room entry, we operate even strabismus now under the microscope. So it helps. You don't need separate tables for them. We don't need separate experience for them to adjust with the loops or anything. So they learn to do strabismus surgery along with their learning of the cataract surgery. So them to be able to understand and handle the operating microscope effectively. For residents, because we train a lot of our residents in this, and of course our senior residents, equivalent fellows, so they need to be working together as a team so that they can enhance each other's skills and manage problems and complications that arise. We have a wet lab training facility which started off as a cataract where 15 hours of active wet lab time was necessary, and we were providing them a proper certification. Of course, that is for cataract surgery before they are allowed to handle any patient. We've moved, and I'll show you how to incorporate strabismus also into this wet lab. So we have this National Surgical Skill Development Center at the RPC where we give them hands-on training. There is the growth side that we arrange for them. The surgery simulator is there, and of course with advanced training modules effectively for cataract. Surgical videos. So there are a period of discussion of surgical videos. We have all residents and fellows record their surgeries, and randomly or once a week each is selected to bring out one of his videos, and at the end of the week on a Saturday we have these presented and discussed to the entire group, so that again it's not something that is judgmental there. It's not that why and what about that person, but it is just to understand and let everybody gain from the experience of problems and complications and challenges that each and every person actually faced, and therefore that recording can help in that general discussion. And of course a wet lab logbook where each and every person's surgery is mentioned. So this is our wet lab where of course this was for cataract, and we kind of modified this to start talking about extraocular muscle surgery on the growth side. This of course got precipitated by COVID, the very few good things that came out of this. So the entire training of our residents for strabismus was shifted to the growth side basis because there were hardly any surgeries that were being done. So we used to get the entire globe of the goat with the muscles attached, and we would inspect these globes to identify that are all the muscles intact or not, and only those globes were selected. And then we positioned these globes. They were tied at the free end at the origin, which was the origin, at the base of the simulator eye, so that you could produce that little sense of tension on the muscle. So when you pass your hook and you're passing your sutures, you get that feeling of true passage of the suture. Again, the globe, as has been mentioned, the goat's eye is a little soft. So when you're passing your sutures through the sclera, you don't get the feel. So we would infuse or push in a little bit of viscoelastic in the globe to increase the turgor pressure, so that they get the real feel of the depth of the sclera when they are passing the suture through the sclera. That is again very important because the biggest risk is the perforation. So we have these residents or fellows go through both resection procedures. We went onwards in COVID to actually work towards giving them a simulation of the complex strabismus procedures for fellows and senior residents, as we call them. So everything from inferior oblique muscle surgery, we would ask them to measure and place the inferior oblique sutures depending upon what surgery. So whether it's any different kind, anteronasal transposition also, they would at least get an idea of how to move the muscle and how to pass the sutures in relationship to the various muscles that are there. Of course, it's not a real feel because really there's no conjunctiva, but it gives them an idea of how to measure on the sclera how to pass the sutures. So again, all these kind of, the superior oblique is also present there on the globe. So it was a very unique experience when we started doing PTSOs for them. So that was very interesting. All kinds of superior oblique procedures, including loop tenotomies, were taught to them on the growth side. So it was all a very interesting procedure. Again, pardon, how to measure, how to get these values. So all these were very hands-on, and an hour of training with them really helped get them get better and better with this. This is an alternative that has been published. Dr. Saurabh Jain has come out with this low-cost strabismus model, which is essentially a golf ball, and using that. But I thought that was more, according to them, low cost. But with the non-veg being eaten in northern India, at least, goat side would be relatively cheap for us. And in the operating room, the other important thing is to have closed circuit LED screens where the surgery can be displayed. Recordings, all residents, when they perform their surgeries have to be recorded. There are, with observer arms, of course, they do not turn 180 degrees completely as they used to earlier, so that is a little bit of a challenge. and as I said, all have to record with the trainer. So this is just showing you how the fellow is operating with an assistant on the side. There is the screen that is there, and that can be instructed to somebody is observing the surgery that's going on. So this is one standard procedure where initially the fellows who are starting off surgery would be in this system here. So before that, discuss the instrument. So the nurse, the surgeon, all should know the sequence of handling and passage of the use of instruments. So first, the non-tooth hook, the tooth hook, the lens hook, and whatever is your surgical procedure. Again, once they see that, they know what to expect as an assistant and as a surgeon. So again, you have the assistant sitting on the side. They can observe almost to the finer detail exactly what you're doing, how you are passing the sutures. Again, while if I'm operating, I will be discussing the surgery simultaneously, so the assistant can understand what I'm doing along with the display simultaneously. So these are all our OR positions where we use both the teaching and demonstrating methods. All these are the discussions can go on simultaneously. These are very key, which we found beneficial. Of course, we have the 3D heads-up display system. We try to use it for strabismus. It is interesting. It does increase the surgical time a wee bit. Good for photographs and good for recording your video, but of course, it does not really add too much. The other thing is, of course, level-based training. You need to have your the kind of surgery that you're training them for intermediate, for beginners, intermediate, and advanced surgeons, and the kind of procedures they do. So your complex superior oblique surgeries, transpositions, all those are, of course, kind of kept for the advanced surgeons, the fellows. The senior should be with them all the time, so that any complication or problem can be actually checked at the same time. As I mentioned, we have them record and we have them discuss subsequently along with the surgical log. There are a lot of competency-based milestones that are there, not so greatly defined from strabismus point of view, but it's an ongoing process. I guess we should have more and more ways in which we will assess them and get better logbooks so that we can finally certify them to the level of competency they have. And finally, of course, discussion meetings, and the best meeting that can ever happen is like the AIOS. So again, advances, of course, like I said, simulation surgeries. Hopefully, they will advance to strabismus also. There is a whole lot of surgeries that they talk about, neurodevelopments in artificial eye, and of course, 3D printed eyes that can be used. So we look forward in the future to get these kind of options available for training our strabismus patients, surgeons. So thank you very much for